Good day to everyone. So, today we are on our final lecture for EENT. So, we are going to discuss the conditions of the inner ear. So, you've already known the other conditions of the ear, such as otitis media, when you were in your second years. So, this time we will discuss the conditions of the inner ear. So first we start out with motion sickness. So it's a disturbance of the equilibrium caused by constant motion. So example are those who are riding a bus or riding a vehicle, such as land transportation, sea transportation like being in boats or ships, or even air transportation like helicopters, airplanes, or jet planes. So there is a discomfort felt when on a moving boat, train, airplane, automobile, elevator, or even a swing. So cause is the irregular and abnormal motion that disturbs the organs of balance, which is found in our inner ears. So clinical manifestations, sweating is one of them. Pallor, nausea, and vomiting. So those of you who are experiencing motion sickness, most especially if you're traveling up to Baguio City, since the road there is a zigzaggy kind of road, you might experience motion sickness. So this is caused by vestibular overstimulation. The vestibule of the inner ear is the one that's responsible for our balance. But if it's overstimulated, these clinical manifestations are going to appear. So it may persist for several hours after the stimulation stops. Management, over-the-counter antihistamines would be very helpful, such as dimenhydrinate or Dramamine. Meclizine hydrochloride antivert. These drugs will relieve the nausea and vomiting by blocking the conduction of the vestibular pathway of the inner ears. We also have anticholinergic agents such as scopolamine patches. This antagonizes the histamine response. Side effects are dry mouth and drowsiness. So this is an example of antivert, and we have Dramamine here. Okay, so here in the Philippines, this drug, meclizine hydrochloride, the brand name of that here is Bonamine. So if you're familiar with the advertisements about Bonamine, about Yahilo or something, that's it. So we can have, these are other examples, transderm sculpts, scopolamine, or Dramamine here. Prevention. So the patient or the person should have or should be well rested and in good health prior to a journey. A cup of strong coffee taken just before departure is also helpful. And during a voyage by boat, it is advisable to remain near the center of the ship, not near the edge of the ship. And some ample fresh air and exercise is important as well. Avoid disagreeable smells because this will further exacerbate the feelings of a person who have motion sickness. Also, of course, avoid overeating before traveling, or else you're going to, if you experience nausea and vomiting, you're going to be vomiting a lot. Car sickness is often relieved if the journey is interrupted for short walks in the fresh air and by keeping a window open. So, if you are going to have a long journey, long travel, let's say for example, you're traveling from Dagupan to Manila, every now and then the driver should need to make stopovers in order for the person who has motion sickness to be relieved from car sickness. Next, number two, we have Meniere's disease. It's an inner ear disorder that can affect hearing and balance to a varying degree. And it's characterized by episodes of vertigo, low-pitched tinnitus, and hearing loss. And it's named after him, the one in the illustration here, after Prosper Meniere. So he's a physician, French physician. And take note, I have experienced this, although I was not diagnosed to have this, but I highly suspect that I have probably experienced this when I was in high school, second year high school, because I remember watching Ghost Fighter, and I am experiencing the signs and symptoms of this disease. So the problem in Meniere's disease is with the fluid inside the inner ear. So it's again a problem within the vestibule, the fluid within the vestibule. Cause, it is again idiopathic, it's unknown. Endolymphatic hydrops. I've already mentioned this earlier. It's excessive fluid in the inner ear. The endolymphatic fluid bursts from its normal channels in the ear and flows into other areas, causing further damage. So that can occur. Membranes can become dilated like a balloon when pressure increases and the drainage is blocked. So this is a cross section of the vestibule where we have the endolymph and the perilymph. These are the fluids that are inside the vestibules of our inner ear. So as you can see here, in a patient with Meniere's disease, for illustration A, as you can see, there's too much fluid building up in the patient's vestibule, unlike that of the normal ones in letter B or picture B. Onset, 40s is the average age of onset, but it can occur to anyone. And it's equally common in men and women. It occurs bilaterally in about 20% of patients. So it's bilateral. It affects both ears. That's what it means. And about 50% have a positive family history. So aside from the patient, other members of the family might be or might have experienced this as well. And we have categories, two subcategories. We have cochlear Meniere's disease. This is without vertigo. So it's fluctuating, progressive sensory neural hearing loss associated with tinnitus and oral pressure in the absence of vestibular symptoms or findings. And we have vestibular Meniere's disease without deafness. So this is the one I have probably experienced when I was younger. So it's characterized by episodic vertigo. So what I felt there is that for a whole week, my vision or my field of vision, my environment is revolving around me. That's what vertigo is. And it's associated with oral pressure, but no cochlear symptoms. Clinical manifestation symptoms are variable and not all sufferers experience the same symptoms. So they may have attacks of rotational vertigo. So that's the one I have experienced, the one I have described to you. So my whole environment is the one that's revolving or rotating around me. Severe, incapacitating, unpredictable. When I had this, I was lying on the couch while watching TV, while watching Ghost Fighter during those days. And it might last for minutes, from minutes to hours with nausea and vomiting. So that's what I felt. And there's fluctuating progressive sensory neural hearing loss for some, although I didn't experience this. And uni or bilateral tinnitus, ringing of the ears of one or both ears. Fullness or pressure, this is the one that we have describing earlier. Oral pressure, fullness of or pressure in one or both ears. I have experienced that. So vertigo is an illusion of motion. So it appears as though you're moving, but you're not. And your whole field of vision is rotating around you. Diagnostics. Physical examination findings are usually normal with the exception of those of the cranial nerve number 8 or the vestibulocochlear nerve. Weber's test is done. So if you recall the test with the tuning fork, you can either do the Weber's or the Rhines test with those. Audiogram is also used together with the electronystagmogram. So that's the electronystagmogram. Just to give you an interesting information about electronystagmogram, what they are doing here is that they are either going to introduce warm or cool water into the ear canal with a syringe so that that water will touch the tympanic membrane or the eardrum, and if ear problems do exist, the eyes are going to involuntarily move to that stimulus on the tympanic membrane. So that's the electronystagmogram. So that's what it is all about. Management, diet and medication. A patient who has this, of course, they have increased fluid in the inner ear, especially the vestibule. They should have a low sodium diet of 1,000 to 1,500 milligrams per day or less. Sodium and fluid retention disrupts the delicate balance between endolymph and perilymph. So we need to lower that down from the patient's diet. A safe, quiet, and dimly lit room together with bed rest is also important for the patient. And emotional support and reassurance to alleviate anxiety because they might be scared that their condition is going to worsen. But this often disappear on its own with this disease, Meniere's disease. Dietary guideline, limit food high in salt and sugar, most specifically salt. Eat meals and snacks at regular intervals to stay hydrated. And eat fresh fruits, vegetables, and whole grains. And drink plenty of fluids daily as well. Limit the alcohol intake because alcohol will complicate things or the signs and symptoms of this disease. Remember, alcohol will already make you feel dizzy if you drink too much of it. What more if you have Meniere's disease? Also avoid monosodium glutamate or betchin because that is also high in sodium. Avoid aspirin or aspirin-containing medications because it will worsen tinnitus, since that's already its adverse effect. Pharmacologic therapy can give antihistamines such as meclizine or antivert, which suppresses the vestibular system. So here again in the Philippines, that is known as Bonamine. Tranquilizers such as diazepam to control vertigo. Antiemetics such as promethazine or Phenergan. This will suppress or control nausea and vomiting, together with vertigo because of their antihistamine effects. Diuretic therapy such as hydrochlorothiazide or triamterene in order to lower the pressure from the vestibule in the inner ear. Surgical management, so they are going to do endolymphatic sac decompression or shunting, consists of draining the endolymphatic sac and inserting a shunt to enhance the fluid drainage. Or they are going to do labyrinthectomy, which involves the resection of the vestibular nerve or total removal of the labyrinth performed via the transcanal route, which results in the deafness in that ear. So here's how they do the endolymphatic shunt. In order to remove the excessive fluid that is building up inside the endolymph. So they're going to create an opening there and shunt it out of the vestibule. So here is another method, the Silverstein microwick, in order to remove the excessive fluid as well building up there. Prevention, reduce salt in your diet. Stop smoking because smoking also can exacerbate this. Avoid exposure to loud noises. It can exacerbate this. Manage stress. Use caution at home and on the job to avoid falling or having an accident if you feel dizzy. Next, we have benign paroxysmal positional vertigo. So this is a brief period of incapacitating vertigo that occurs when the position of the patient's head is changed with respect to gravity. So there's recurrent vertigo and nystagmus, which is not usually associated with any lesions on the CNS, especially in the cranial nerves. And the onset of this is sudden. Cause is thought to be due to the disruption of debris within the semicircular canals. And the debris are small crystals of calcium carbonate from the utricle. And it's stimulated by head trauma, infection, or other causes. But there is a debris inside or within the semicircular canals, and they are made up of calcium carbonate. Severe vertigo is easily induced by any head movement and can later on lead to nausea and vomiting. So just a simple movement of the head can trigger vertigo in the patient. Management is to have bed rest in acute symptom. Meclizine again and prochlorperazine will be very helpful. And PT for balance exercises of physical therapy is also beneficial. Canalith repositioning procedure. This is a non-invasive procedure which involves quick movements and rearranges the debris inside the canal. And this is performed by placing the patient in a sitting position, turning the head into a 45-degree angle on the affected side, and then quickly moving the patient to a supine position. This is in order to move those debris inside the canal. It's safe, it's inexpensive, and very easy to perform, but only a physician is allowed to perform this. So this is how that canalith repositioning procedure is done, also known as the Epley maneuver. So there. So you can see based on the illustration here, so the particles, the calcium carbonate in the semicircular canals will be moved. Once the clinician rotates the patient's head towards the affected ear, then lowers the patient backward to the supine position with the head hanging over the table's edge. And the head is turned to the other side. Head is turned further so that the ear is parallel to the floor, and the head may be rapidly turned even further to almost facing the floor. Then the patient is returned to the upright position and the head is rotated back to normal in order to reposition those particles within the semicircular canals. Next, we go to tinnitus. It's a perception of sound in the absence of corresponding external sound. It might be mild or severe. It's not a disease, but it's a symptom of other conditions that can result from an underlying cause. So it's described as ringing, swishing, roaring, buzzing, or hissing sound in one or both ears. So it can be unilateral or bilateral. And it is associated with hearing loss. And it's prevalent between the ages of 40 to 70 years of age. And it is a subjective phenomenon. It's only the patient who can hear that ringing in their ears. Factors may be due to ototoxic substances such as aspirin. We have other diuretics, chemotherapeutic agents, anti-malarials, anti-inflammatory, aminoglycoside, metals, and chemicals. So drugs initially can cause ototoxicity. Disorders such as thyroid disease, hyperlipidemia, vitamin B12 deficiency, psychotic disorders, pathologic and neurological disease, And loud noise exposure. So for example, during New Year, you've used firecrackers and you've used Goodbye Philippines as a firecracker and you came too close to it that it exploded, let's say 2 meters away from you. You will experience ringing of your ears if you hear a loud noise. Management: reduce or avoid caffeine and salt intake together with quitting smoking. Avoid also exposure or being exposed to loud noises and loud sounds and noises. Reduce anxiety and try to stop worrying about the tinnitus. Often the more you worry and concentrate on the noise, the louder it will become. So you need to do activities that will distract you from the ringing of the ears. Next we have labyrinthitis. So this is the inflammation of the inner ear caused by either a bacteria or a virus. Bacterial infection is rare. It's already a complication of otitis media if it's not treated. Viral is more common and affects hearing and balance. Due to viral is usually caused by complications from mumps, rubella, rubeola, and influenza or upper respiratory tract infections. Clinical manifestation is sudden onset of incapacitating vertigo with nausea and vomiting, and various degrees of hearing loss since it's already the labyrinth that is involved. The inner ear itself. Tinnitus will also be heard by the patient. In the first episode is usually the worst. Subsequent attacks, which usually occur over a period of several weeks to months, are less severe. Management, of course, for bacterial, IV antibiotic therapy is going to be done together with fluid replacement. Antihistamine and antiemetics if the patient is experiencing nausea and vomiting together with vertigo. Viral, it is based on the patient's symptom. So for viral, it's just supportive treatment. They might be given antihistamines and antiemetics as well. Antivirals if it's already complicated or if their condition is already complicated. Next, we have ototoxicity, ear damage, specifically the cochlea or auditory nerve in the vestibular system, which is caused by a toxin, usually a drug. So that's medication induced, like aspirin, ASA or acetylsalicylic acid, and quinine, which is an anti-malarial drug. These drugs can cause irreversible hearing loss. And ASA, especially if the dosage is increased, will produce bilateral tinnitus. Aminoglycosides, they destroy the hair cells in the organ of or teeth, especially if you give them in high amounts. Aminoglycosides are examples of or are a group of medications under antibiotics. Management: patients should be counseled about side effects of these medications, and drugs should be used with caution to high-risk individuals, especially the elderly. Blood levels of the medication should be monitored, like, for example, giving quinine or aspirin. Next, we have acoustic neuroma. This is a slow-growing benign tumor of the cranial nerve number 8, or the vestibular cochlear nerve. It's usually arising from the Schwann cells of the vestibular portion of the nerve. So mostly arise within the internal auditory canal and extend into the cerebellopontine angle to press on the brainstem, which destroys the vestibular nerve further. So most of these type of neuromas are unilateral, so one-sided only. And they both occur in men and women equally at any age. So as you can see here in this illustration, the tumor is growing there in the cranial nerve number 8. So that's what happens with acoustic neuroma. Assessment findings: Unilateral tinnitus and hearing loss with or without vertigo is the most common. Most acoustic tumors have damaged the cochlear portion of the cranial nerve number 8 and hearing is already impaired. MRI with contrast media is done in order to visualize the tumor. Make sure to check for allergies with the contrast media before MRI is going to be done. CT scan with contrast media also. Check for allergies for the contrast media before these diagnostic procedures will be done. So what the doctor is going to do is to remove the tumor surgically, and that is the treatment of choice, because these type of tumors, they do not respond well to radiation and chemotherapy. Interdisciplinary treatment approach is needed by consulting both a neurologist and a neurosurgeon. And the complications of surgery can be the following: facial nerve paralysis, because the facial nerve might be affected here when doing the surgery. CSF leakage, because remember, the cranial nerves, they are connected to the central nervous system. Meningitis can also occur. Cerebral edema as well is also one of the complications. Aural rehabilitation will be done on the patient. The purpose of this is to maximize the communication skills of a person with hearing impairment, which includes auditory training, speech reading or lip reading, speech training, and the using of hearing aids or hearing guide dogs is very, very helpful. And since this is unilateral, when talking to this patient, make sure to talk to the patient on the unaffected ear. Take note, you should talk to the patient on the unaffected ear, because the patient is not going to hear you that well if you're going to talk to the patient on the affected ear. So there, teach them also how to use sign language. So dog guides for hearing aids. So it's a device through which speech and environmental sounds are received by a microphone, converted to electrical signals, amplified, and reconverted to acoustic signals. So this here is an example of a hearing aid. It's battery powered and there's a volume control on and off switch. So there you go. So the hearing aid may make sounds louder, but it does not improve a patient's ability to discriminate words or understand speech. Hearing aids amplify all sounds, including background noise, which may be disturbing to the wearer. So that's it for our topic regarding the years. So thank you very much, everyone, third years, for attending all of my video lectures. I appreciate you watching all of them, and thank you for enjoying this semester with me. I hope to be teaching you again in the next semester. Most probably you will already be having your CA1 during that time. You will already be fourth years at that time. Since you're already done with research as well, you have lesser loads for next semester. So thank you very much. Good luck on your upcoming exams and enjoy the sem break afterwards. Again, thank you very much for listening. Have a great day to everyone. Bye.